Good evening, everyone, and a warm welcome to all the faculty and the delegates who have joined this scientific program. It is titled SEPSIS, Current Prospective and Future Paradigm. And also, we will have a special panel discussion on sepsis in special populations. So, once again, warm welcome to all of you. Thank you for joining in. Next slide, please. Before we start, I just give you a brief introduction of Microlabs, who has organized this program. Microlabs, established in 1973, it's a fully integrated pharmaceutical company which is present across the entire pharmaceutical value chain, starting from research and development to active pharmaceutical ingredient to finished formulation or to marketing and distribution of these products in India as well as overseas. Microlab is a privately held company founded by late G.C. Surana ji. Now it's under the leadership of his sons, Mr. Dilip ji Surana and Mr. Anandi Surana. Microlab has its vibrant presence over 15 countries, both all the US, UK, European countries, Southeast countries across all both developed and developing ROW markets. And it has more than 3,300 product registration at various stages. In India, it is 18th rank as per the IQVIA. And Microlab has 14 state-of-art manufacturing plant, which is approved by all the regulatory bodies of the world, which includes UK, US FDA, UK MHRA, TGA Australia, WHO, and our own DCJ. And it has a state-of-art R&D with more than 400 professionals working with us. Next slide, please. With regard to its scientific activity, Microlab is involved in a lot of academic and special initiative. We have for Fever Foundation, which has a lot of activities of fever in adults and pediatrics, and we have modules for paramedics. We do conference on especially for fever, and we have regain program done for postgraduate DM student. We have interesting cases in diabetics, and for cardiology we have lipid registry, hypertension registry. We have in-home BP monitoring initiative. So more, and also we have allergy foundation, lots of allergic activity, allergy 360. It's a module based activity, a certificate courses, and live ENT surgery workshop. And we have also GRD. So it has a multi-therapy area and multi-therapy activities. Next slide, please. And we bring about a lot of books, and we have bought about nearly 14 books in under fever, and both for pediatrics, fever in children and fever in adults. Next slide. And apart from books on fever, we also bring about other books in cardiology and diabetology, like diabetes management, which we do every year. We have brought about almost 21 years. We are bringing up the books on fever, diabetes management, and cardiology updates, and cardio-diabetic interesting cases, as well as the ENTs, etc. So these are the few examples of the books we bring about. Next slide, please. With regard to today's program, on the occasion of SEPSIS World Sepsis Day, which happened on September 30th, so we want to continue and start our activity, our actually contribution to how to control this most challenging condition. As we know, sepsis remains one of the most challenging conditions even in modern medicine, and it continues to be leading cause of mortality worldwide. Its data shows is once in 5 deaths globally as well as of today with the advancement. And that's hence we have organized this scientific program to deliberate both the clinical evidence and practical consideration, what are the future available, and what are the things which can do to reduce the mortality. So that's why we coined the term as sepsis in the current perspective as well as future paradigm. Next slide. So to help us in conducting the session, you can see we have a very big faculty list. All are eminent in their therapy area. So we are very, very fortunate to have them today here under one roof. So we will be starting the session, and I have the pleasant task of introducing the chairperson of today's session, Dr. Pradeep Rangapasa. Next slide, please. Who does not require any introduction, but as a formality, I'll be doing so. Dr. Pradeep Rangapasa is a senior consultant, critical care at Manipal Hospital, and he has several positions which he has held. Just to paucity of time, I'll be saying sir is the president-elect of Indian Society of Critical Care Medicine, and he's been the organizing secretary for various conferences of critical care, GAPO, GSES. So all of you are waiting to listen to him. So without wasting much time, I would hand over the session to Dr. Pradeep Rangapasa. Sir, over to you, sir, to take up the session. Thank you very much.
Good evening, friends. Good evening, everyone. Thanks, Dr. Manjula, for giving a good overview and the context setting for today's meeting. So, we are indeed privileged and honored to having distinguished doctors here on the forum, especially considering this day is very special for us that it's a World Sepsis Day that happened on 13 September 2025. And we are here to discuss various dimensions of sepsis going forward and interesting scenarios that we have on board to discuss and tease out the salient points to take home with regards to optimal management and saving more lives. So that is the context setting for this meeting. So I have a pleasure of inviting Dr. Simon Nuddle, who is a pediatric intensivist at St. Mary's Hospital, England. So, welcome aboard, Dr. Simon. I'm sure your talk and insights will add immense value for the proceedings of today's conference. Welcome on board, Dr. Simon.
Thank you very much. Thank you for the introduction. Thank you for inviting me. Just for your benefit, just to make clear, I'm a pediatric intensivist, and my talk will cover some pediatrics and some adults, but the concepts really are pretty much the same. So if I could have my first slide, that would be grateful, please. Thank you. So as I say, I'm a pediatric intensivist. I've worked in pediatric intensive care for 35 years with an emphasis on research into the presentation, management, and outcome of pediatric sepsis primarily. I've been involved in developing national and international guidelines for the management of sepsis, meningococcal disease, meningitis, and other critical illness, primarily in children, but also involved in developing adult guidelines. So I'll start with where we were 25 years ago or so, when we used to see a lot of children like this with overwhelming meningococcal infection and purpura fulminans. And I'm going to talk now about the definitions. My talk will cover definitions, pathophysiology, treatment options, and some discussion of future options. So just to be aware that we always used to think about the definition of sepsis being infection with the systemic inflammatory response syndrome, but then it became increasingly obvious and apparent that many patients with sepsis did not develop the systemic inflammatory response syndrome. So this study from 2015 showed that in Australia and New Zealand, out of over 100,000 patients with infection and organ dysfunction, over 12% did not develop the systemic inflammatory response syndrome. And this led to the concept and the definition of sepsis according to the third international consensus definition, which has now come to define adult sepsis. So sepsis, after this large data survey, sepsis was then defined as a life-threatening organ dysfunction caused by dysregulated host response to infection. And septic shock was a subset of sepsis in which the underlying circulatory and cellular abnormalities were profound enough to substantially increase mortality. And according to these definitions, patients with septic shock could be defined with a clinical construct which involved persisting hypotension requiring vasopressors to maintain a mean arterial pressure greater than 65 millimeters of mercury and a lactate greater than 2 millimoles per liter despite adequate volume resuscitation. And with those criteria, when this definition was identified, the hospital mortality was in excess of 40%. So huge mortality according to these definitions. And these definitions define sepsis as relatively new concepts. they defined that sepsis was the primary cause of death from infection, especially if not recognized and treated promptly. It was a syndrome defined and shaped by pathogen and host factors, for example, age, sex, genetic factors, comorbidities. Sepsis was differentiated from infection by the dysregulated host response, as I've just stated, and the presence of organ dysfunction. And it was made clear that sepsis-induced organ dysfunction could be occult. Therefore, in anyone with infection, there should be consideration of whether there was any underlying organ dysfunction. And conversely, if you found new onset organ dysfunction, you should look for unrecognized infection. And it was made clear in these definitions that specific infections could lead to local organ dysfunction without leading to a dysregulated host response, such as in focal pneumonias or infective arthritis or meningitis. So the presence of local infection does not mean that the patient has sepsis. And following on from those definitions, a group of investigators looked through over 3 million patient records to define the new Phoenix criteria for pediatric sepsis, which, as I say, looked at over 3 million case records from both high-income and low and middle-income countries to develop a validation set which defined that a score of 2 points or more in a child with suspected infection would be sepsis, and sepsis with 1 or more points for cardiovascular dysfunction would be equivalent to septic shock. And these were the scores. So there were scores for respiratory, which looked at the presence of ARDS, cardiovascular dysfunction, which 1 point was scored for the need for vasoactive medication and a lactate greater than 5 millimoles, and 2 points for vasoactive, two vasoactive medications and a lactate greater than 11. And the score really was derived from respiratory, cardiovascular, coagulation, and neurologic criteria. And just to remind you, a score of more than 1 point for any cardiovascular criteria was equivalent to septic shock in children. And from this Phoenix sepsis score, which was developed last year, a Phoenix sepsis score greater than 2 in patients with suspected infection was considered to be sepsis. Sepsis with 1 or more cardiovascular points was called septic shock, and children in this over 3 million patient record database, children with sepsis in the first 24 hours had a 7% mortality at the higher resource sites, but that increased to more than 28% mortality in the lower resource sites. And children with septic shock in the first 24 hours had a nearly 11% mortality at the higher resource sites and nearly 34% mortality at the lower resource sites. And it was felt that this definition was more relevant than the previous definition, which was developed in 2005. And just going on, I know you're all highly qualified and highly experienced, but just to remind you that shock is defined as a failure to deliver oxygen and nutrients to the tissues. And shock results from inadequate oxygen delivery relative to oxygen consumption and or impaired oxygen utilization, leading to tissue hypoxia and cellular necrosis and organ dysfunction. And it's important to remember, particularly in children, shock is not necessarily a problem of blood volume, cardiac output, or blood pressure, but it is always a problem of inadequate tissue oxygenation. So it's important to remember that in children, particularly, hypotension is a late sign of shock and develops late in the course of sepsis. Accordingly, tissue hypoxia or shock results from 1 or more of the following mechanisms: impaired oxygenation, inadequate oxygen carrying capacity, impaired cardiac output, or impaired cellular utilization of oxygen. And the clinical recognition and assessment of shock is really vital to the appropriate treatment. And it still really involves serial physical examination, accurate interpretation of hemodynamic and laboratory data, which are both essential for a timely and accurate diagnosis of impending or existing shock. And I'll come on to talk about how important early diagnosis is shortly. So this is another child with overwhelming meningococcal infection. And just to go back to pathophysiology, it's important to realize, and although this is meningococcal disease mortality in the UK, you could draw the same graph pretty much for any acute infectious disease mortality. So you can see from this graph, which goes back to before 1930, that before the introduction of antibiotics, sepsis due to any organism, in this case meningococcal infection, was almost universally fatal. And then sulfonamides and penicillin their use became prevalent. And around just after 1940, with the introduction of penicillin, the mortality from meningococcal disease and many other infections fell to around 15 to 20%. But you can also see from this graph that there was no significant change in the outcome of meningococcal infection for the next 50 to 60 years, which was very disappointing. And that's despite the introduction of increasingly powerful antibiotics and increasingly complex organ support systems. So this is a micrograph of the meningococcus, and you can see it's a diplococcus, so there are two organisms stuck together, but you can also see in this diagram these blebs of bacterial cell wall which are forming in the surrounding fluid. And this bacterial cell wall contains the virulence factor of gram-negative organisms, which is endotoxin. And these were graphs that were developed in the 1980s. I know you can't see them very clearly, but these were graphs that looked at the amount of endotoxin in the circulation on admission of patients with meningococcal infection. You can see, I'm sorry, I can't point out, but on the left side of the graph, this was the amount of endotoxin in the circulation, and the text that you can see on top with the arrow says penicillin and chloramphenicol, and you can see as soon as penicillin and chloramphenicol are given, the amount of endotoxin in the circulation falls very dramatically. And the graph on the right shows the amount of endotoxin in the blood of patients with meningococcal disease who've been given antibiotics prior to admission, showing logs less amount of endotoxin in the circulation of those patients, which was really the basis for the concept that you should give antibiotics as soon as possible in patients with meningococcal infection. And that concept is correlated and transferred to most other acute bacterial infections. And we know from lots of laboratory and other studies that endotoxin, and you could add to this figure exotoxins and other bacterial virulence factors, are detected by by host cell wall receptors and translate into intracellular upregulation of an inflammatory response, leading to the release of cytokines and other effector molecules, which have their effect on host cell processes. And the pathophysiology of sepsis, it has become very clear that it involves increased capillary permeability due to interactions with the endothelial cell surface and changing endothelial cell function. That also causes a disturbance of vascular tone. So in some vascular beds, there's vasodilatation, and in other vascular beds, vasoconstriction. The disruption of the surface of the endothelium leads to disseminated intravascular thrombosis, leading to microvascular thrombosis in many organs and tissue systems and organ failure. And it's important to remember that the heart is lined by a modified endothelium, and the same processes that are occurring in the vascular tree are also occurring in the heart, leading to depression of myocardial function. And myocardial failure eventually happens due to a multitude of factors, including capillary leak, which, as I've mentioned, is due to endothelial dysfunction, leading to a reduced circulating volume and reduced preload. The presence of acidosis, tissue hypoxia, metabolic abnormalities, including hypoglycemia and other electrolyte disturbances, reduced coronary perfusion and myocardial cell necrosis, cardiodepressant factors released by bacteria and also released by host cells, including tumor necrosis factor, interleukin-1, nitric oxide, all combine to lead to myocardial failure. And we see this picture with patients who, after fluid resuscitation, develop this gross edema, primarily due to capillary leak and myocardial failure. And we know that despite a very improved understanding of the pathophysiology of sepsis, treatment currently is primarily centered around the early identification of patients with sepsis, prompt and aggressive treatment with antibiotics, aggressive volume resuscitation, organ support, and the avoidance of nosocomial complications. So what can we do to try and improve the outcome of sepsis? Well, we know that the treatment of septic shock is to treat the underlying cause with, as I've said, early antibiotics and aggressive source control if there are infected nidus of, say, abscesses or empyema, or infected intravascular devices. Removal is important. Rapid intravascular volume expansion guided by clinical examination and serial measurement of urine output and evaluation for fluid overload. And I'm going to talk about the evidence for the resuscitation in pediatric septic shock, where rapid fluid resuscitation up to 60 mils per kilo in the first hour, or maybe beyond 60 mils per kilo, is associated with improved survival. It's important to remember that in children, the blood volume is roughly 80 mils per kilo. So, replacement of virtually the whole blood volume in the first hour is associated with improved survival. And just to go back to early treatment. So this is, I'm sorry, I don't know if you can see the top of the slide, but this is a paper that talked about appropriate antibiotic therapy resulting in a 5-fold reduction actually the title is Inappropriate Antibiotic Therapy Results in a 5-fold reduction of survival in human septic shock. This was published in 2009 and was a retrospective survey of nearly 6,000 adults with septic shock. And it looked at the survival after appropriate or inappropriate antimicrobial therapy. And you can see here that even with appropriate antibiotic therapy, only 50% of patients survived. But if they did not receive the right antibiotics or they received them late, only 10% of patients survived. So this is really going back to the pre-antibiotic era, showing how important antibiotics are. Then further discussion about appropriate treatment. In children, septic shock is nearly always associated with hypovolemia, and that's a combination of children often prior to developing sepsis have been febrile and vomiting and may have diarrhea, and they're not eating or drinking. So septic shock is nearly always associated with hypovolemia. And mortality in children is more associated with a reduced cardiac output rather than excess vasodilatation, which is commonly seen in adults. And this study, which looked at children with sepsis being treated by district hospitals in the United States was a study that was published in 2003 and showed 91 children with septic shock, of whom there was nearly a 30% mortality, showing that early appropriate treatment with volume rather than inotropic support was associated with improved outcome. And this study showed that shock reversal within an hour and a quarter was associated with 96% survival, with an odds ratio for survival of greater than 9 times. And this study showed that non-survivors were treated with more inotropes compared to those who survived, but did not get increased fluid therapy. So non-survivors were treated with more inotropes, but not more fluid. And they also showed that, so this study really showed that shock reversal, early shock reversal, was really vital. And the authors here, including Joe Carcillo, which is a major player in the understanding of treatment of sepsis, showed that each additional hour of persistent shock was associated with a doubling in the odds of mortality. So for every hour, your risk of death was doubled. And then in the UK, we showed here, this was a study looking at 200 children with sepsis referred to retrieval services over a 6-month period in 2008, with a 17% mortality. And we showed that 139 children were shocked at the time of PICU referral, but those with shock reversal by the time of PICU admission, so the time was around 3 hours between shock referral and PICU admission, had a better outcome compared to those where shock was not reversed. So there was only 6% mortality in the group which reversed shock versus a 25% mortality of those who remained shocked at the time of PICU admission. And the only variable independently associated with death in PICU was the presence of shock after inter-hospital transfer. And we know with the resuscitation of shock how important it is to use lactate as a marker of the adequacy of resuscitation. And this was one of the first papers which looked at the difference between outcome in those, this is adults with septic shock, those who were able to normalize lactate had a 93% survival compared to those who were not able to normalize their lactate or clear lactate, where only had a 67% survival. So this is using lactate as a marker of the adequacy of resuscitation. So I'm just going to talk a little bit about the surviving sepsis guidelines for the management of organ dysfunction and septic shock in children. So in healthcare systems with the availability of intensive care, it's recommended that you give 40 to 60 mils per kilo in fluid boluses, 10 to 20 mils per kilo over the first hour, titrated to the clinical markers of cardiac output and discontinued if signs of fluid overload develop. But it's important to remember, and I think this is particularly relevant in your setting, in healthcare systems with limited availability of intensive care in the absence of hypotension, it was recommended against bolus fluid administration, but while starting maintenance fluid. And I'll come on to talk about the evidence for that shortly, which I'm sure you're all aware of anyway. And in healthcare systems with limited availability of intensive care, if hypotension is present, then it's recommended that up to 40 mils per kilo of fluid boluses are given in the first hour, with titration to clinical markers of cardiac output and discontinued if signs of fluid overload develop. And this was the algorithm for the Pediatric Surviving Sepsis campaign. This is published in 2020. So the first thing clearly is recognize shock within 1 hour. And within an hour of recognizing shock, obtain intravenous or intraosseous access, collect a blood culture, start empiric broad spectrum antimicrobials, measure lactate, administer fluid boluses if shock is present, and start vasoactive agents if shock persists. And if you think there's only initial suspicion of sepsis, you've got 3 hours to do that. And then continuous reassessment. You can see at the bottom of the slide, it says, think about using hydrocortisone for refractory shock, avoid hypoglycemia, and use antimicrobial stewardship. And it also talks about the possibility of using ECMO for refractory shock or oxygenation failure after excluding or addressing other causes of shock and respiratory failure. And this is talking about the healthcare systems with or without intensive care. And I talked about the difference between giving fluid boluses where you have intensive care present, and if you don't have intensive care availability, then do not give fluid boluses unless there are signs of severe dehydration. So which fluid should we use? I've said we should use 10 to 20 mils per kilo boluses, 40 to 60 mils per kilo in the first hour. If no response to volume, then you should use vasoactive agents. And there is good evidence that there's increased length of stay on the ventilator associated with fluid overload and possibly an increased risk of ARDS. So which fluid should we use? So I think you're probably all aware of the studies of artificial colloid solutions in adults with severe sepsis and septic shock, showing the increased risk of particularly renal failure and coagulopathy with starches and with artificial colloid solutions. So they are now no longer recommended. This study that was published in 2004 looked at the use of either saline or albumin in patients in intensive care units. And despite the fact that there was a suggestion of an improved outcome in patients being treated with albumin, which you can see halfway down this graph, those with severe sepsis seem to have an improved outcome with albumin, although it wasn't statistically significant. It's now recommended that crystalloids are used for the management of patients with sepsis and septic shock. And there's been multiple studies of comparison of balanced crystalloids versus normal saline. And this is one of the first studies that was published in 2014, showing that the higher proportion of balanced crystalloids that were used in adult patients with septic shock, the better the outcome. And you can see along to the right-hand side of this graph, where nearly 100% of fluids were balanced crystalloids, the mortality was significantly reduced compared to the use of saline. Similar analyses have been done in children, and this was a large meta-analysis looking at over 12,000 patients from 8 studies, comparing balanced crystalloids to saline. And that, in fact, there was no statistically significant difference in the outcomes of patients with either balanced crystalloid or saline. It seemed in this retrospective study that the hospital length of stay was significantly longer with balanced crystalloids compared to saline, but hyperchloremia and the need for renal replacement therapy was significantly reduced in those with use of balanced crystalloids compared to saline. And a lot of the discussion about how much fluid bolus should be used in children with septic shock has come from this paper, which was published in 2011, which was primarily a study of the use of saline versus albumin. It was meant to be in children with severe malaria in Africa. But what this study showed was that using albumin boluses or saline boluses both led to a mortality of over 10% in these children, but where just maintenance fluids were used without a fluid bolus, there was a 30% relative risk reduction in mortality. So this is really the basis for the Surviving Sepsis campaign in children, recommending no fluid bolus in children with sepsis where there is no access to intensive care. And it's important to remember that the concept of fluid overload in adult sepsis is really derived from the studies from ARDS, which basically showed a significantly increased time on ventilator with a liberal fluid strategy. So ventilator-free days in the top there in the conservative strategy were significantly, they had significantly longer, more ventilator-free days than in the liberal strategy in adults with ARDS. And we've shown similar outcomes in children where fluid overload in 48 hours is associated with prolonged length of stay on the ventilator, but not mortality. And it's now very well recognized that there are 4 stages of volume resuscitation therapy. Rescue, where fluid resuscitation is aggressively needed, optimization of fluid status, then stabilization, and then de-escalation phase, where the aim is to liberate the patient from all the excess fluid that they've received with either aggressive diuretic therapy or hemofiltration. I'm not going to talk about that, but I'm going to talk about the vasoactive agents that are currently recommended. So everyone knows about the early goal-directed therapy, where this study from 25 years ago now in Chicago showed that with early aggressive goal-directed therapy, which included optimization of CVP, mean arterial pressure, central venous oxygen saturation, led to a significant reduction in mortality in those treated with early goal-directed therapy. And this strategy has been adopted widely in the adult world now. And interestingly, there were 3 further studies published around 10 years ago now from Australia, United States, and the UK, which basically showed no impact of the use of protocol-based early goal-directed therapy or standard therapy compared to usual care. And it's felt to be the reason for that being that usual care has really adopted the principles of early goal-directed therapy. So when you added central venous oxygen saturation and optimization of hematocrit to that, it didn't really make any difference to outcome, because the standards that were suggested by Emmanuel Rivers and colleagues in 2001 have really been very well adopted in adult practice. So just talking about the use of vasoactive agents. So the Surviving Sepsis campaign in 2020 for children, I think very similar to the adult Surviving Sepsis campaign, suggested using either epinephrine or norepinephrine rather than dopamine for vasoactive support. They were unable to issue a recommendation for specific first-line infusion for children with septic shock, so either epinephrine or norepinephrine as the first-line infusion, guided by clinician preference, individual patient physiology, and local system factors. We know very well now that you can give these vasoactive agents through peripheral access without needing either intraosseous or central venous access initially, and there's been a paper published very recently showing that you can give prolonged norepinephrine, noradrenaline through peripheral lines in adults. They went on to further suggest adding vasopressin or further titrating catecholamines in children with septic shock who require high-dose catecholamines. And they weren't able to issue a recommendation about inodilators, which I know are very commonly used in adult practice. And just to go through the data for this, so this was the study of vasopressin versus norepinephrine, the VAST study in adult patients with septic shock, showing essentially no difference between using vasopressin or noradrenaline as first-line vasoactive agent. But in children, there's pretty good evidence that vasopressin used certainly in high doses is not associated with an improvement in outcome and may be associated with an increase in morbidity, particularly ischemic events, including peripheral limb, digital, and gut ischemia. And there was no obvious benefit for vasopressin. And in adult practice, I know angiotensin II has now been licensed for the treatment of vasodilatory shock based on this study, which showed that angiotensin II significantly increased mean arterial pressure. But it's important to remember that the use of angiotensin II is also associated with an increase in essentially thromboembolic events and some ischemic, peripheral ischemia. And there have been some studies of the use of beta blockers for reduction of tachycardia and reduction of cardiovascular complications, including tachyarrhythmias in adult patients. And there has been some meta-analyses that suggest benefit for adults with septic shock, but there's been no well-conducted controlled clinical studies of beta blockers in adult sepsis since this study was published. And talking about targets for blood pressure, there's now fairly good evidence that it's not beneficial to aim for a higher blood pressure target. And this study that was published in 2014 showed there was no significant difference in mortality in aiming for a lower blood pressure target of 60 to 65 compared to 80 to 85 millimeters of mercury, which also showed that if you aimed for a higher blood pressure in adults with septic shock, there were higher incidence of tachyarrhythmias. And based on this adult study, we're now in the middle of this protocolized evaluation of permissive blood pressure targets versus usual care in children, where we're targeting a lower mean arterial pressure target, which is the 5th centile for age. This is a large 1,600 patient study that should finish in the next year. So just talking about the future. So despite an increased understanding of what the processes and the pathophysiology of septic shock and various studies of all of these agents to try and interrupt this pathophysiological cascade, including activated protein C, anti-TNF, anti-IL-1, various other antioxidants, vitamin C. There's been no proven benefit from interrupting this cascade, and the only thing that's been proven to improve outcome is early antimicrobial therapy. So what can we do? So the Surviving Sepsis campaigns have shown that if you introduce a guideline protocolized management, and the top graph here is the number of sites that have utilized the Surviving Sepsis guidelines as a bundle. And the bottom graph is the improvement in mortality in adult sepsis associated with that introduction of these bundles of care. And in children, we're finding similar systems and similar improvements and similar evidence. So this study looked at the introduction of a 1-hour bundle of care, which was blood culture collection before antibiotics, administration of broad-spectrum antibiotics within the first hour, completion of a 20 ml per kilo fluid bolus. And this shows the outcome when, according to time of completion of the 1-hour bundle. So you can see the in-hospital mortality where the 1-hour bundle was completed within an hour was around 7%. But if this bundle was delayed, you can see there's a stepwise increase in mortality. So if the 1-hour bundle was only completed after 4 hours, there was a 14% mortality, so a doubling in the mortality, showing how important these bundles of care are. So the therapeutic principles are that hemodynamic support should optimize perfusion to vital organs, ensuring adequate oxygen delivery. Vasoactive drugs should be titrated to specific targets that reflect optimal end organ perfusion, including urinary output, lactate clearance, and more recently, non-invasive measures of cardiac output. Mean arterial pressure reflects tissue perfusion, but specific organs have different tolerance to blood pressure based on their ability to auto-regulate. And there's clearly a threshold mean arterial pressure where tissue perfusion is dependent on blood pressure. But we don't really know what that is accurately. But the optimal arterial pressure target for patients with shock is debated, particularly in children where their blood pressure is dependent on age. Vasoactive drugs have a narrow therapeutic spectrum, so you can expose patients to potentially lethal complications if they're not tightly controlled. They require precise targets, close monitoring, as we've said, and the use of vasoactive agents in shock requires an individualized approach, probably dependent more now measured with more accurate ways of measuring tissue perfusion and cardiac output. Vasopressin and possibly angiotensin II may be useful owing to their catecholamine sparing effects. And essential questions about blood pressure support that remain include the selection of the appropriate agent, the appropriate escalation, sequencing, and there's been more recent data showing that early introduction of vasopressin may be beneficial, combination regimens, and dose titration. Now, the other thing I haven't really talked about, and I'm coming to the end of my talk now, is the use of steroids, corticosteroids, and the recommendations, similar to the adult recommendations, are not to use steroids if you can fluid resuscitate and use vasoactive agents to restore hemodynamic stability. And basically, you can use steroids if you want, if you are not able to restore stability. And there's been many studies now showing that steroids may or may not be beneficial in patients with septic shock. And some more interesting data comes from studies such as this, and I know there have been studies such as this in adults, showing that there are specific patients who may or may not respond to corticosteroids. And depending on their genetic upregulation of inflammatory mediators. So this study looked at children with immunoparalysis as a primary feature of their septic shock. And the top graph shows patients with septic shock. On the left at the top is patients without immunoparalysis, where there was no significant impact of steroids. But patients with immunoparalysis, and going to the right of these graphs, showed a longer duration of multiple organ dysfunction. So patients with immunoparalysis, so a specific subset, showed a worse outcome with the use of steroids. And there are now clearly patients where you can measure their endotypes, which is their transcription of their genetic signature of immune response for determining precision therapies in sepsis. And I think this is going to be coming to the fore in the next few years to determine what is the right treatment at the right time for the right patients. So individualized precision medicine for patients with septic shock depending on their immune profile. But what can we do? I think all we can do at the moment is stop sepsis with appropriate immunization, certainly for children, early recognition, early antimicrobial therapy, early intervention to prevent organ dysfunction until these newer methods become prevalent. So thank you for listening. I hope that's been useful for you, and thank you.
Thank you very much, Dr. Simon Nadal, for this wonderful exposition on the sepsis with the context of pediatric population. So I'll open this discussion for questions and answers, even from my esteemed panelists who will be there. So I just would like to introduce our other members on board today, Dr. Anirban Home Chowdhury, who is the head of department and director of Safdarjung Medical College Hospital at New Delhi. So welcome on board, Dr. Anirban.
Thank you very much, Pradeep. Can I have a question for Dr.
Yeah,
Simon?
just before you ask question, Anirban, let me get my other esteemed panelists also, so that we can have a good sort of a discussion and a deliberation on what Dr. Simon has deliberated upon.
Of
So
course.
can I introduce Dr. Raymond from Chennai Apollo Proton Hospital, who is the head and director of ICU at Apollo Proton from Chennai. Welcome aboard, Dr. Raymond. So.
Hi, hello everyone. Good evening.
Thank you, Raymond. And have a pleasure to welcome Dr. Subba Reddy, who is the HOD and the Director of Intensive Care at Apollo Hospital, Hyderabad. Dr. Subba Reddy, welcome on board.
Good evening. Thank you, sir.
Yeah. So, Dr. Simon, all are very leading intensivists in our country. So, we are privileged and honored to deliberate on this with our good friends and academicians from intensive care in India. But I have to confess, all of them are adult intensivists, Dr. Simon. So, we got a very good perspective on the pediatric oversight. I think Anirban is inching to ask you a question. Before that,
I was inching to ask a question, but before that, I request you to introduce Dr. Abhijit Bhattacharya.
Yes. Sorry, I was just about introducing Dr. Avijit Bhattacharya. Is a leading physician from Manipal Hospital, Dakuria in Calcutta. So welcome on board, Dr. Avijit.
Good evening and thank you.
Yeah, so we have a galaxy of intellectuals, Dr. Simon, from across India, from north, east, west, and south. So Anirban, you can start off with your question, then maybe I will give in some comments, and then maybe others also can pitch in with their questions. And in relation to pediatric, how we are a little bit different from adult
we are
perspective.
a little bit different, maybe much different, but still there are some similarities in the midst of similarities. Just like for intellectuals, the IT uses the term intel. So similarly, between pediatrics and adult and sepsis, there are some divisions which are variable. Dr. Simon, I want to ask you a simple question that often perplexes me, that in pediatric patients, we can have both cytokine storm and immune paralysis happening together simultaneously. The fact which is conceived by scientists as cytokine paradox. Now, what is the cause, and is it related to multi-organ dysfunction? Does it lead to early multi-organ dysfunction?
Thank you for that question. It's a very good question. I don't know the answer of. I mean, I don't think anyone knows the answer, but it's clear that there are certain patients where the cytokine storm includes cytokines that reduce immune function, such as interleukin 10 and various other cytokines. So, you know, there are pro-inflammatory and anti-inflammatory cytokines, and the immune phenotype depends on the balance between those cytokines. And it's clear that there are some patients where immune response is downregulated in the acute or subacute phase of sepsis. And they're the ones I was talking about, where they seem to have a worse response when they're treated with corticosteroids. And I think that's also been shown in adult patients. So that's why it's important to try and understand the immunophenotype of before intervening. I don't know if that's answered your question, but I think it depends.
Thank you so much.
Depends on the balance.
Any other comments or questions from other panelists? Yeah, Dr. Simon, I had a little comment regarding some of the guidelines you were suggesting. So you did mention there's a large trial which said the balanced solution were found to be superior in pediatric population. But we have sort of realized, although there was this enthusiasm of using balanced solution, but as of now, I think in adult population with the recent studies, especially the basic study and a few other newer trials, so we are sort of reconciled that still saline holds good, and even in patients with traumatic brain injury, we believe balanced solution may be more harmful. So what are your comments when you made a mention that balanced solution in pediatrics was found to be superior in reducing the mortality, Dr. Khanna?
No, sorry if that I didn't say that. I said there was no in the meta-analysis in children. There was no difference in mortality or morbidity, but it seemed that the incidence of hyperchloremia was reduced, and possibly more patients ended up on renal replacement therapy with treatment with saline. So I'm sorry if I didn't make
Yeah,
that
great, great.
clear.
So
But
the
similar
norm
to the
remains
adult
that
studies,
saline is
yeah.
good enough for pediatrics, Dr. Khanna.
Saline's good enough, but I think there is a complete move away from saline and towards balanced crystalloids in pediatric sepsis. So I think the recommendation now from the next iteration of surviving sepsis guidelines for children would be for the use of balanced crystalloids and against the use of
One small question, one small query, Dr. Simon. In adult patients, we rely very much on capillary refill time because that is an indicator of perfusion. Very simple, easy to perform bedside. The Andromeda shock trial has shown us. Why it is of so limited significance in pediatric patients? Why you don't rely on capillary refill time in pediatrics?
we do rely on capillary. So capillary refill time is an important part of the initial and repeated clinical evaluation of patients with sepsis. So capillary refill time, core peripheral temperature gradient are used widely in the resuscitation of children. So
But they say it may be normal in children with sepsis.
well, I think in children with conditions such as toxic shock syndrome, where you get erythema, vasodilatation, capillary refill time may be normal, but there are a small subset of children with septic shock. So it's used widely. Capillary refill time is used widely in children with septic shock. Remember, children get cold very quickly, so they peripherally vasoconstrict even when they're not septic. So it may be a less reliable sign in children than it is in adults.
Thank you.
Can I get Dr. Subbareddy? Because I think he must have logged out.
He is the panel moderator.
Yeah. So because I don't see Dr. Subbareddy. Yeah, so I think there are a few questions on the chat box, Dr. Simon. So what about the role of immunomodulators in pediatrics? Because I know that there is some sort of an evidence for use of immunoglobulins in children, which we do not use in adult population. So your comments on why the difference of the immunomodulator usage in pediatrics vis-a-vis adults, Dr. Simon?
Yeah, there is no indication for the use of IV immunoglobulin in children with sepsis, apart from children with toxic shock syndrome due to group A strep or staph toxic shock. So that's the only indication. There is no other indication. So it's very similar to adults, where I think IVIG is recommended in toxic shock syndrome, necrotizing fasciitis.
Yeah.
So,
Thank you. And is there role for extracorporeal measures in pediatric population, Dr. Simon? Like in adults,
So
we
good
use
evening all.
cytokine removal, membranes, and endotoxin removal,
Can you?
hemoperfusion, so on and so forth. So is
yes,
there any evolving evidence in pediatrics whether you would have group of patients where you see a distinct role for these, Dr. Simon?
yeah. So endotoxin removal columns like cytosorb and various other columns have been used in small numbers, particularly in children with liver failure. they're not widely used in pediatric sepsis. No, ECMO has been used, obviously, in children with intractable cardiorespiratory failure. Its use in sepsis is not really indicated because the mortality is more than 50% in children with sepsis going on to ECMO. Hemofiltration, renal replacement therapies have been used, particularly high volume hemofiltration, with no evidence of improvement in outcome. Plasma exchange has been used. Very much like adults, there are various small case studies, cohort studies of the use of these extracorporeal therapies without clear evidence of benefit.
Dr. Simon, one small question I had, because we always in adult sepsis patients give reference to FEAST trial in pediatric patients, FEAST, 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 which was
Yes, I
conducted
talked about
in
it in my
African population,
yes,
and which showed higher mortality among children where fluid doses were given. Now, is that something which was unique for African children, or is it true for even in high resource ICUs in the other parts of the world?
yes. So it's important to remember the FEAST study was done in very low resource settings without access to intensive care. Many of the hospitals that were involved in the FEAST study didn't even have oxygen therapy. So this is really confined to low income, low resource settings, and that's what the surviving sepsis guidelines. That's what they refer to when they say don't give fluid boluses if you do not have access to intensive care. So if you have access to intensive care, the recommendations have been unchanged. So aggressive fluid resuscitation. But in low resource settings, the recommendation is not to give fluid boluses unless you have access to ventilatory support, intubation, inotrops.
Thank you so much.
So, Pradeep sir, can we go ahead with the panel? We'll have a few questions and then we'll wind up.
Yeah, that will be nice,
And,
Subhareddy. You can start off the panel.
Yeah, with
so
your
the whole you can give the
yeah.
context setting, Subhareddy, and then start off the panel.
Yeah, sure. So the sepsis remains a global challenge, demanding health rapid innovation, and then we need a multidisciplinary care. And sepsis management is bread and butter for any intensive care physician. But when it comes to sepsis in special population, it's very difficult in diagnosis and management we face challenges. So with this, I would like to start the panel discussion on sepsis in special population. I'm trying to share my PPT. If they can allow that. Can you share my PPT?
If they are not able
Dr.
to load, you can go ahead with your impromptu questions.
Yeah, now I can see. So the first question to Pradeep sir. Sir, in pregnancy, diagnosing sepsis is a challenge because of the physiological changes what we see in pregnancy. And can you enlighten on this? How to recognize sepsis early in a pregnant patient?
Yeah, so I think this is a very good question, Dr. Subba, because the physiological changes in pregnancy itself is quite remarkable in that they generally have a lot of physiological changes which can confound certain traditional features that we look out for in sepsis. Like typically pregnancy, they would generally their heart rate would be a little higher, and they would be generally a bit tachypnic because of their functional residual capacity, which would be lowered. So this would confound the tachycardia, how we interpret, because the baseline heart rate itself would be a little higher and they would be tachypnic. But these are the features we depend on when we are ascertaining the sepsis. And the relative blood pressure in pregnancy generally is a bit low. And if you look at the systemic vascular resistance, there is a general reduction in systemic vascular resistance in pregnancy by 25 to 30%. So deciphering the blood pressure and whether we would accept a map of 65 for pregnancy. So these are some of the challenges that we would have in determining whether there is a sepsis, and identifying early on in these patients can be a challenge because of these baseline features. So high index of suspicion is something that should be there, and generally they have a little lowish hematocrit, oncotic pressure will be low, some edema would be there. So there are a lot of physiological changes which tend to make it little difficult to recognize and identify sepsis. So we may have to apply multimodal ways alongst with biomarkers, alongst with the clinical, alongst with the monitored variables, alongst with the investigative parameters, and have a high index of suspicions in establishing the diagnosis of sepsis, Subha.
Yeah, I completely agree with Sandeep sir having a high index of suspicion. And the people who are working in obstetric critical care units, they will have more experience, and then but the other people from other units where there is less of exposure to obstetric critical care units will become a challenge. Next question to Anirban sir. Sir, how does immunosenescence? We know with aging, the immunity will go down, and we see various problems when the immunity goes down in elderly people, including autoimmune processes, physiology, or sometimes the cancer markers will we see when there is low immunity. So, identifying sepsis is also a challenge in elderly people. And what are the risk factors in geriatric population when it comes to sepsis?
Yes. So, the immunosenescence is a age-related decline in the immune function. There is a state of chronic inflammation with age. The technical term for it is inflammaging. And because of inflammaging, all the circulatory levels of CRP, IL-6, etc., live slightly above the baseline. And because of immunosenescence, the T cell function is impaired. In immunosuppression, both the T cell and the B cell functions are impaired. So a patient has both has difficulties in phagocytic activity, the phagosomes are not formed, and also the antibodies are not produced. With age, the problem of immunosenescence leads to a decline of the T cell activity in particular. T cell activity may be normal, not be normal, but T cell activity is reduced. So they have increased preponderance for infection. The fever may not manifest. So the patient may have altered mental status, may have apathy, may show change in behavior, but may not manifest fever. The CRP, IL-6, etc. will lose their significance, although the PCT is something which will be unequivocal. So PCT level is not going to change. Considering other risk factors for sepsis in elderly patients, Subba Reddy, the most important ones today are those related to sarcopenia. And sarcopenia and the general loss of this body mass is perhaps poses a challenge in addition to the debility, because these patients are very labor. They are frequently they lead to falls, and because of falls, again everything becomes a part of the vicious cycle. So the presentation and the course of sepsis is altered on account of this. The other important risk factor are the presence of comorbidities. If the patient is aging, also has a coexisting diabetes, liver disease, kidney disease, etc., then a certain amount of organ dysfunction has already set in this patient. If on top of it the patient contracts sepsis, then that automatically the sepsis is likely to have a more fulminant course, and chances of progression to multi-organ dysfunction is much higher. So these are some of the risk factors which we can think of when we consider this in the context of aging population.
Thank you, sir. Next to Dr. Rahman. Dr. Rahman, you're working in one of the apex cancer institutes of the country, where you'll be seeing a lot of oncology patients. So, what clinical features may be atypical or masked in immunocompromised patients with sepsis?
Thank you, Dr. Subbareddy. So I'll try to be as simple as possible in good interest of time. A lot of it has already been discussed by Dr. Pradeep and Dr. Anirban. So typically, not just cancer, any of these immune compromised individuals, we're not going to have any of the classical signs of infection, or rather than saying not going to have, it may be blunted, or it may be on the other side, or it may just be a little delayed, because most of these clinical manifestations of infections are driven by inflammatory mediators, which are going to be less when you have, say, typically a neutropenia, or when you have macrophage dysfunction or immunosuppression. So, therefore, classical signs like fever may be there, may not be there, or it could become hypothermia, or maybe it is out of proportion. In other words, the infection is probably more severe, but looking at the patient, the severity or the grade of fever might be a lot less, or the fever might just come in way later. Likewise, when there is neutropenia, there is no question of expecting to see a rise in neutrophils. Neutrophilic leukocytosis probably doesn't happen at all. The classic shift to left and all that, which we talk about, I don't think that really happens. And more intriguing is that, we don't even have these inflammatory cells infiltrating into the focus of infection. Like, for example, you could be having a thrombophlebitis without any of the classical signs that we see. You could be having a pneumonia without an X-ray actually manifesting an infiltrate in the early stages, where you're supposed to really, jump in and act. Unless we're going to be doing CT or PET imaging to identify all these instances of very early infection. Similarly, often we see meningitis without the classical signs of meningeal inflammation. And most of the times, what triggers the diagnosis is some vague manifestation of organ dysfunction itself in the first place. This is also probably the reason there's a lot of research happening in trying to identify biomarkers for organ dysfunction as the first line, diagnostic aids in sepsis. So a high index of suspicion, and don't run after classical signs. Thank you.
Thank you, Dr. Next, to Dr. Avijit Bhattacharya, sir. In your experience, you may be seeing patients with nephrotic and then nephrotic syndrome. Sometimes when they develop sepsis, how these patients, why these patients with nephrotic syndrome are more predisposed to sepsis?
Thank you, Dr. Subha. I think if I can describe the predisposition in three factors. One is immune phenomenon, particularly because of the loss of immunoglobulins, because they have a massive proteinuria and they lose a lot of immunoglobulin G, and that impairs the the immune function, as well as they lose a lot of complement factors. So the complement mediated bacterial killing is also impaired. There is some dysfunction with the T cell also, and these patients also have because of the the edema in the serosal cavities, other things, which acts as a sort of reservoir for infection. The infection can start there, as well as if you have poor tissue perfusion, your neutrophil migration is also impaired. And thirdly, because of their treatment, again the immunity gets impaired. You often give steroids, so that can have more chance of bacterial fungal infection. If you give maybe mycophenolate, you can give rituximab. So everything impairs the adaptive and innate immunity. So because of the immunoglobulin loss, because of treatment-related factors, and because of the edema, they are predisposed to sepsis.
Thank you, Dr. Bhattacharya. We'll move on to Dr. Simon. You had extensive presentation about the sepsis, pediatric sepsis. I think you already discussed, but if we can briefly, in 1 minute, if you can tell us the important indicators, how to differentiate adult sepsis with pediatric sepsis.
Yeah, thank you. Thank you for the question. So I think it's very similar to adults. I think the important thing is in young babies, infants, the classical signs of sepsis may be different to how they appear in older children. So obviously, young babies can't localize. They can't tell you where they can't speak to you. So changes in behavior are very important. So lethargy, pallor, tachycardia, impaired capillary refill, cold peripheries, vomiting and diarrhea are extremely common as non-specific signs of sepsis in young babies and young children. Hypothermia as opposed to hyperthermia. But really the signs are tachycardia out of proportion to the amount of fever, lethargy, vomiting and diarrhea, sometimes febrile convulsions, there's fever, maybe non-specific markers of infection in young children. It's important to look very carefully. And also trying to distinguish viral from bacterial infection may be very difficult. So having a high index of suspicion, understanding whether the child is immunized or whether they have any other predisposing factors to infection is really important as well. And that's why the use of broad spectrum antibiotics is very common in young children until we can understand whether they have an invasive bacterial infection or not. I hope that's helpful.
Yes, I completely agree. I think from all the discussions, we understood the high vigilance in the healthcare providers and bringing awareness in this special population about the sepsis and their clinical science is very, very important. So we'll move on to again, Pradeep sir, another question for you. And what type of pathogens are commonly implicated when it comes to maternal sepsis, and how do they differ from the general ICU population?
Yeah, thanks, Subha. So I think for sepsis, when we talk about pathogens, obviously in normal population, we try to identify the source and possible organisms from those sources, isn't it? Like if it is
Yes.
UTI, we have common organ. But in pregnancy, in maternal sepsis, it is a little different. So we generally, if you look into the literature, is categorized as chorioamnitis, which is more commoner, or endometritis, or it is a postpartum mastitis, or is it a septic abortion. So these are the four categories that one would look at and the associated organisms. So when you talk about chorioamnitis, in most of these four categories that I mentioned, chorioamnitis or endometritis or postpartum mastitis or the puerperal sepsis or septic abortion, the organisms are predominantly Streptococcus, group B Streptococcus or Staphylococcus. And when it comes to sort of a chorioamnitis, there are some distinct organisms like Urea plasma, Urea liticum, or Gardnerella vaginalis. But generally, the common organisms will always be group B Streptococcus or Peptostreptococcus or Enterococcus fecalis, so on and so forth. So when we talk about endometritis, also predominantly the group B Streptococcus figures out, Staphylococcus comes, and E. coliforms also come. And even with mastitis, these are the common organisms. When it comes to septic abortion, again, these are the prevalent, and Enterococcus fecalis, E. coli, and group B Streptococcus and Staphylococcus. So pretty much they are repetitive, especially in maternal. Group B Streptococcus seems to be the commoner organisms, along with other conventional bugs that we come across like E. coli and Enterococcus fecalis. The unique organisms are Gardnerella vaginalis, Urea plasma, Urea so on and so forth. So these would be the broad categorization when we look at the maternal sepsis. But of course, when they are in ICU, it's a different story. You may have any other exotic flora that we tend to see. But when you specifically talk about pregnancy, this is how it is categorized generally, Super.
Next, Professor Anirban Chaudhary. How does polypharmacy and altered pharmacokinetics in elderly impact your antibiotic selection and dosing? These people will be having a lot of drugs in the medication chart. So, how do you think this polypharmacy will affect?
Absolutely, Subhareddy. The polypharmacy is a very big challenge and in the cause for deterioration of the patients unless the drug-drug interaction is known and carefully adjusted, titrated, or certain drugs are discontinued. For example, when you are using clarithromycin along with beta blockers or calcium channel blockers, these patients can have a steep fall in their blood pressure. So you have to be careful that what is the mean blood pressure before administering such drugs. Similarly, if there is a patient of beta blocker, they can have masked hypoglycemia. So even during choice of antibiotics, you can miss certain points when the patient is hypoglycemic because it will not reflect the true picture of the blood at that point of time. Secondly, when we are using drugs which have a mimetic effects or not mimetic effects, which causes muscle weakness, the aminoglycosides, the cholesterol, etc., then that potentiates all the weaknesses, etc., of the muscles. And these patients can also tend to have a delayed weaning or a failed weaning. One has to understand the pharmacokinetics by simply looking into the fact that an elderly patient is normally dehydrated. The total amount of water is less in his body. So certain drugs which are hydrophilic, they tend to have an increased concentration in the plasma, and for which their side effects are suddenly increased risk of side effects. On the contrary, the lipophilic drugs require a higher than dose administration provided the end organs are normal. So these particular facets should be carefully considered by any physician while choosing the drug and also choosing the correct dose in elderly patients.
I agree with you, sir. And in my experience, I have seen these people developing hypoglycemia when we continue both anti-diabetic medication and antibiotics. So that is one concern. So we need to keep in mind that these people will have comorbidities and then they'll be taking medications for that. Coming to Dr. Rahman, how does the type of immunosuppression uh, influence the risk for the specific pathogen?
Yeah, this is definitely important because the nature or the line of immune suppression really decides the spectrum of pathogens, and we need to know this to be able to get the empiric therapy right in most of the times. Like, for example, typically patients who have neutropenia. Neutropenia is the first line of defense against all gram positives, gram negatives, all the bacteria. And you tend to get the typical bacterial infections, whereas in prolonged neutropenia, you also run a severe risk of developing fungemias. When the problem is with cell mediated immunity, like for example, we see after solid organ transplants or in HIV individuals where we have issues with the CD4 cells, the spectrum is usually revolving around intracellular pathogens, notably bacterial intracellular organisms like Mycobacterium tuberculosis or fungi like Pneumocystis. We have the Cryptococcus, Histoplasma, or even parasitic infections like Toxoplasma, and for more important, viral infections. How did I place that last? That's even more priority. That's the herpes simplex, varicella, cytomegalovirus, and all those. If the problem is with humoral immunity, the antibiotic deficiencies, maybe in situations like multiple myeloma or after rituximab and such agents, we could have issues with encapsulated organisms. In fact, where there is an IgA deficiency, you may be exposed to a big risk of gut onset sepsis of any nature because the first line of IgA is lost over there. In other instances, you need to just imagine how this antibody works. It's supposed to opsonize and present the organism to the complement system. So this whole process is lost for whatever encapsulated organisms that these antibodies are targeted against, like the Streptococcus, Haemophilus, and so on. We can have problems with complement system also, but this is usually rare. We don't see that so too often in adults and in sepsis. And the other is also looking at skin and mucosa as a potential immune system. So when you have mucositis or when the skin integrity is lost, that is also to be seen as a potent or a form of immune suppression. So they're the typical colonizers, streptococci, staphylococci, any of the fungi. These are all the organisms. So we need to run this algorithm in the mind as we face patients, more and more of these patients with immune compromise, and have necessary fine tunings made to the empiric therapy. That is very important.
Thank you, Dr. Raymond. Next, Dr. Bhattacharya. Uh, which infections are most frequently seen in nephrotic syndrome patients when it comes to organism site? Any difference?
Again, taking cue from Dr. Raymond's, what he said just now, it mostly affects the encapsulated organisms like strep pneumoniae and Haemophilus influenzae. And not only that, the problem with the combating this infection is also becomes very challenging because of the antibiotic distribution while you have a hyperalbuminemia. So I think vaccinating these patients against these infections are very important while you start treating these patients. Not only pneumococcal vaccinations, while we have got a conjugate vaccine now for pneumococcus PCV20, which is available in India now. So one should definitely consider vaccinating against pneumococcus. If it is children, particularly Haemophilus influenza vaccination is also important. And influenza often carries a secondary bacterial infection risk, so they should be ideally vaccinated for influenza as well. And if you have a long-term immunosuppression in these patients, I think hepatitis B vaccinations also should be on the cards. So infection is basically encapsulated, and wherever it is feasible, one should try to vaccinate these individuals.
Thank you, sir. Next, again, Dr. Simon. So you already discussed the fluid resuscitation strategies in your presentation. So we can change the question with your permission. Are you using any AI tools or genomics, proteomics when it comes to personalized sepsis therapy in children, or any role for vaccination? Already Dr. Bhattacharya told few vaccinations will help in preventing sepsis in children. Can you enlighten on that?
Yes, thank you. So I think the use of genomics, proteomics is becoming increasingly used as a research tool. It's not used. There's currently no clinical application of these tools, but I think in the next 5 years, the personalized, individualized care, these will become, particularly as a diagnostic method to try and distinguish viral from bacterial infection, to help with antimicrobial stewardship, to determine, when is the appropriate time to either step down antibiotics or to start antibiotics. So I think in the future, these tools, in the near future, these tools will become important in clinical practice. As far as immunizations are concerned, there's a whole raft of vaccines to try and prevent young children who are particularly at risk of invasive bacterial and viral infections in early life because of the immaturity of their immune system, to prevent them. So particularly maternal vaccination now has become increasingly important to prevent pertussis in young childhood, to prevent influenza in young childhood and infancy, and to prevent RSV, which is a big cause of morbidity and some mortality in children in the developed world. And I know is associated with a high amount of mortality in the lower and middle income countries. So RSV vaccination of mothers and immunization with monoclonal antibodies is becoming increasingly introduced into routine practice in many parts of higher income countries. I don't know if you have any of those vaccines in India. And then the vaccines against pneumococcus, Haemophilus, and meningococcal disease that we use in early infancy in the first year of life, and subsequently measles, mumps, rubella, along with the normal infant schedule of tetanus, diphtheria, and polio. So they're all vital, and we've just introduced now in the UK chickenpox varicella vaccine, and rotavirus vaccines in infancy. So a broad array of vaccines to try and protect the young child from severe infection. Okay.
You are muted, Subba Reddy. That's why you are not heard.
Yeah, I can see the question. Subba Reddy, with
Yeah,
your permission.
sorry. I completely agree with Dr. Simon. And then we have a very strong immunization schedule in India in the pediatric population. I think we are exceeding time. We will not take this third round of questions. I think we will conclude. I think if any of the panelists, if they want to say as a conclusion remark, you allowed, we can conclude. Pradeep sir, what do you say? It's already 6:15.
Yeah, so I think on this World Sepsis Day, I think we've had a very elaborate discussion on the various dimensions of sepsis and sepsis in special category. But what we can largely agree upon as a new concept that has evolved, Subba and Dr. Simon and all the esteemed panelists, is recently you may have seen the chain of survival in sepsis that has come. So possibly we should emphasize more on this chain of survival as the first step when we are addressing the sepsis, because sepsis is a huge problem with a multi-dimensional sort of a syndromic situation. So maybe adhering to the principles of chain of survival is something that we can all agree upon, where it emphasizes on three aspects actually, which was interesting to me. Maybe I need quick comment on this because it's important, where they have put oxygen and early antibiotic use and fluids as the three important dimensions. Because if you recall the earlier 1 hour bundle, we had send blood cultures first, then get a lactate, then give fluids, vasopressor, so on and so forth. But here there has been a renewed emphasis on oxygen and antibiotics and fluids, and continuously looking for the source of infection, continuous and addressing the source. I think these two from the clinical dimension becomes important, although there are other dimensions which talk about critical care beyond the walls, which means you should not wait for ICU for the sepsis management to continue. It should continue with available resources wherever the patient is, even if it has to be pre-hospital. And they talk about post-intensive care sort of a problems and public awareness. So these are the salient elements of this sepsis chain of survival. Quick comments from each one of you, because this is a new concept that has evolved, where oxygen has been put in the forefront along with antibiotic and the fluids. So quick comments, and then we can wind up, Subba, if you're okay. I think this is a
Pradeep,
contemporary topic.
you have said very rightly about survival, the chain in context to sepsis, but one which is going to be the biggest challenge in the coming days with an increasing aging population world over, including India, is the post-intensive care syndrome. This post-intensive care syndrome will take a very big shape. This was first diagnosed by an American singer, Billy Porter, if you must know and we all know. Although if those who have watched the versions of Grey's Anatomy in the Netflix, you will know that Meredith, that how it was wrongly labeled as post-traumatic stress disorder, although that individual is a distinct. So it has cognitive impairment, it has physical impairment, it has mental depression. So this is going to be one big challenge which is going to which every physician in intensive care will be going to face in the coming days, and we should adopt a strategy, focus and direct our resources, our academia into taking for this challenge.
Dr. Subbareddy, can I just make a comment?
Yes, sir, please.
Yeah, I think, we are still stuck somewhere. Like oncology, we have not progressed as far as personalized medicine is concerned. I think that is the way forward. We have to identify different phenotypes. All individuals do not respond in the same way. So we have to identify people who will respond to particular treatment regime. We cannot make a blanket prescription for everyone. That is where we are stuck. And oncology has advanced very far with a,
And that is impossible in sepsis. That is impossible in sepsis because sepsis is
to
not.
try to find, because with
We
this,
can keep chasing, but however, you might twist to the dog's tail to make it straight. It can never get twisted because sepsis is the final culminating point of several diseases, and therefore we cannot identify all the phenotypes and genotypes of sepsis, and therefore the targeted therapy will always remain a dream in sepsis therapy.
That is because sepsis is a syndrome. Breast cancer is a diagnosis. Ovarian cancer is a diagnosis. Sepsis is a syndrome.
I disagree. I mean, much as those studies of hydrocortisone in various populations, I think you can get rapid diagnosis of endotypes or phenotypes in sepsis, and you can personalize treatment depending on what's found. I think that's where we're going in the next few years. And until then, the early antibiotics, early rapid resuscitation is all we can really do. I think, we can get point of care genotype or phenotype coming very soon, within an hour of presentation. So I think that will help to determine which vasoactive agent to use, whether to use steroids, whether to use other immunomodulating agents. I think it's coming in the next 5 to 10 years.
Whatever immunomodulating agents have been used, Professor Simon Nadel, with all due respects, have all revolved a full circle with work done is equal to zero. And therefore, when we see ultimately at the crux of the matter, the independent outcomes that we have assessed, we always find that every study is ultimately repeating the same algorithm and trying to fix a problem whose source is still unmet.
I agree. It's been
I
depressing.
think we're exceeding time. So by understanding more phenotypes in sepsis, and then AI coming, like AI tools in sepsis, genomics, proteomics, wearable sensors to monitor these patients remotely, and then the tele-ICU platforms will help us in managing patients who are away from cities and where there are the specialists are lacking. Definitely multi-pronged approach, multidisciplinary care in managing sepsis in special population is very, very important. I think with all these, with this continued education and then innovation, I think we can turn the tide against this life-threatening condition. Thank you so much. And over to Dr. Saurav, or the micro labs.
They have left.
Yeah, no, he's there. Right. Dr. Saurav is there. Yeah.
I thought we are only left.
No, Dr. Krishna is going to give us the vote of thanks. Dr. Krishna is there. So, in their absence, let me give this one sincere gratitude to all the panelists present over here. Dr. Simon Nadel, for your fantastic talk on the current and the future perspective of the sepsis, and really appreciate Dr. Subba Reddy for moderating the session and coming out.
We lost the voice, I think, isn't it?
We lost the voice.
Yeah, we lost the voice.
So we really thank all the panelists to be present over here. Professor Anirban Home-Chaudhary, Dr. Raymond Simon, and Dr. Abhijit Bhattacharya, Dr. Subba Reddy, Dr. Pradeep Rangappa sir, and Dr. Simon Nadel. Thank you very much for coming onto the session. Thank you, sir. Thank you very much.
Thank you. Thank you, Professor Dr. Simon. Thank you, all my good friends. Have a great day.
Thank you so much.
Thank you, sir.
Thank you, everyone. Bye.